So the topic is what the savvy reader wants to know. Last year I talked about machine learning in medicine, but I wanted to bring it back to basically what's published today and the problems that exist today as opposed to the future. So if we're looking at data today, there's hundreds of orthopedic journals that are published. And so when we have that much literature to sift through, we need effective ways of weeding out the garbage or the fake news, so to speak. And we have to be choosy about what we read. There was an article from 2009 that looked at how many orthopedic papers were published a year, and that was 7,000, and they predicted that the number would grow by 10% every year. So that means this year there were 15,000 orthopedic articles that were written, and there was 74 orthopedic journals that were indexed. Depending on the resource that you use, this is Simago, there's 266 orthopedic journals. So if you're going to sift through the data of today, I think it's important to have a cursory understanding of statistics, even if you don't know all the details behind it, because it's part of the methodology of the studies that we read. And saying I critique the study design or I critique the methodology of the study, but I don't understand statistics, doesn't really make sense, right? Our field is rapidly changing. We publish manuscripts, and there are the most current chapters or textbook chapters of today. So saying I don't understand statistics is like saying I don't understand how to read the textbooks of today. If your brain works like mine, there's a finite number of penguins that can sit on top of that iceberg. So why should you dedicate your energy to paying attention to what I'm talking about today? Well, because you probably want to know enough to be dangerous, at least a passing familiarity of the pitfalls and the shortcomings of common study designs prevent you from making mistakes or being misled by the data. And this way, we take responsibility for ascertaining the truth of studies, and we're not relying on statisticians or epidemiologists or reviewers or even editors for that matter. We've all seen reputed journals where the mechanisms of review have failed and we don't really agree or the results don't really make sense. So the goals are how to efficiently sift through the literature, identify red flags without being an expert in statistics, and raise awareness of common misconceptions. And my goal is to do this without completely nerding out. You snooze, you lose. So getting the most out of the journals that you read, no one is born a good reader in science, and so you follow a few key principles. I think you need to have a screening approach to decide quickly what articles you're actually going to delve into, decide what questions those are going to be for you, and utilize available critical reading tools. So deciding what to read, my method and what Seth Leopold talks about in his core editorials is basically picking 2 high-quality general orthopedic journals, 1 subspecialty orthopedic journal of interest, and then just a high-quality medicine or science journal. If you just pick 4 journals, you will already have more articles than you could possibly read in a month. So then the question becomes, if I read this conclusion, would it matter to me? So you need some kind of resource to amalgamate all the papers, right? So for most of us who have Apple devices, that's Apple News. And the equivalent to that in the research world is Read by QXMD. And Dr. Brodke actually pointed me towards this resource, but this is essentially my news feed when I'm looking at articles. And then you can filter such that you're following certain journals. So for me, it's JBJS Core, JOT is the specialty journal, and then JAMA is the high-quality science/medicine journal. There's red numbers here that indicate how behind I am, so I haven't read JBJS in a while, and it tells you that. Then if you click a journal, it will tell you how many articles are being published that month, and the benefit is that you're not waiting for them to be printed. It's published ahead of print, and so you can just keep up with it as it's being published. And then you click a specific article, it'll have tags like whether it's multi-center, retrospective, or randomized, and then quick links for you to download it. And if you're someone who likes to do this on the fly, then there's an app that will do the exact same thing, not only by journal, but by keywords. So if I put acetabular fracture in there, it'll index across all journals, not just the 4 that I picked. And so then if you're on the hospital network here, or you're just walking in between spaces, I do my sifting of papers there, push it to papers, and then I can read it on my desktop at a later time. So then Papers, Mendeley, ReadCube, Zotero, these are all different reference managers. Papers 3 is probably the most familiar to us. but it may be going by the wayside because it was just absorbed by ReadCube, so we'll have to see what happens over the next year. But it looks something like this. You have smart folders on the left, you have keywords on the right that you can tag your papers based off of, and then you can create smart folders based on criteria, so it organizes it for me. So now I have a system where I've decided what I'm going to read, at least from a cursory standpoint, and then I'll look at the methods section to see if I'm going to actually delve deeper. The methods has two main aspects to it. One is the validity, and when we're looking at external validity, that's basically, do the results generalize to the patients that I'm looking at? And bias, which is the internal validity, which is, methodologic rigor, and we'll go into that. But the 4 questions that I ask for external validity apply to all study designs. And the questions are like, does it apply to my practice? Community versus academic medicine. Do the patients in the article look like my patients? Does my skill compare to the surgeon's? So if it's someone who's done 1,000 superior capsular repairs and I'm about to do my first, I shouldn't expect that my results are going to be akin to what was published in the paper. And then, are the technology and facilities used in the study available to me? And this was something that came up in India a lot, because if you're thinking about obvious things like computer navigation and robotics, sure, they don't have that. But what about experienced anesthesia? I mean, the thought of keeping someone under for 5 hours to do an acetabular fracture is unheard of. So you have to think about what resources they might have had available to them in the study. After you do that, you'll ask yourself internal validity questions. JAMA's released a book that basically talks about different study designs and what questions you would ask. It's pretty good. But CORE actually has reviewer tools too. And I would use those at least initially to read a paper critically. That's what the reviewers are using anyways. And those depend on the study design and help you identify sources of bias quickly. This is, again, our readout process when we're going through the literature. So for retrospective studies, you want to see what patients were included, but also what were the indications for them to actually get a procedure. Was the follow-up sufficient for them to look at the outcomes that I actually care about? And were the outcomes validated with some robust tool? Same questions apply to prospective studies, except now randomization may come into play. So what randomization scheme did they use? Were the providers blinded to it? And was intent to treat analysis used? If you're looking at diagnostic tests, you want to see if the gold standard was applied. So like if you were thinking about the RIDE-FAST study, how many of those patients actually got CT scans to confirm that there was a posterior malextension present? Was it selectively applied only to those for which the diagnostic test was positive, or was it applied to everyone? And then the last one is systematic reviews or meta-analyses. And you want to know whether they've described their search criteria adequately. So if you read those, could you apply the same search criteria and get the same results? Do the authors address when not all studies are of the same quality or similarly convincing? And what happens if you're including studies with different effect sizes or if they point in different directions? That's heterogeneity. And without getting into the nitty-gritty of the statistics behind it, the big picture is like, suppose you had 5 studies, 5 said that they're a positive result, and then you had another 5 where there was a negative result. The question becomes, well, how do you weed through those? Which ones of those are true? And so you want to ask the author of the questions, and you would hope that they would report why there's those differences among studies. Do the patient populations differ? Do the treatments administered, were they administered differently? And then was the follow-up sufficiently long in positive studies to get your negative outcomes? Or vice versa, if there was delayed gratification after a surgery, did you follow them long enough to get that positive result? So that ends the barrage of, questions that you would ask for a study to screen between them. So you look at journals, topics, and authors. You use some service to amalgamate it for you, like a reference manager, and you apply a set of screening questions to it. And then the next question is, well, then how do you interpret the data? And I focused on 3 areas of misconceptions that were pervasive to the literature and were most surprising for me. The first was that odds ratios are commonly mistaken for relative risk. And physicians think in terms of probability. Gamblers think in terms of odds. But the odds, if you were to look at it, and I'm not talking about odds ratios, is basically the probability of an outcome occurring versus it not. So if you're looking at mortality and you say the mortality is 30%, the odds of mortality is 30 over 1 minus 30, so it's like 30 over 70, 43%. Already a little harder for us to wrap our head around. As the probability approaches 0, your odds approaches your probability. And so like if the mortality were 5% instead of 30%, the odds is 5.2%. So for rare events, the odds ratio approaches the relative risk ratio. The problem is, in the literature that we publish, rare events don't commonly get published, right? Because it's hard to study them. And the only way we really study them is case control studies. So what is the odds ratio? It's the risk factor contributing to a clinical outcome of interest versus, the risk factor not being present and the odds of that. So if we're looking at mortality in smokers, you would say the odds ratio is the odds of mortality in smokers over the odds of mortality in non-smokers. Already I was confused. Most of you are probably confused about what this odds ratio represents. But know that you can't use relative risk to calculate it. Relative risk is based on probabilities. Relative risk is what we understand. You can't get an odds ratio from a relative risk. Furthermore, if your probability increases, the relative risk and the odds ratio disperse. And so if I say that it's a rare event, mortality is only 1% in men and 0.5% in women, my risk ratio is 2, it's fairly similar. I get the same odds of 2 if there's 50% mortality in men and 33% in women, 80% mortality in men, 67% in women. So you see the problem in the odds ratio. I have the same odds ratios, I have widely varying probabilities, and the relative risks tend to diverge the more prevalent it becomes. Odds ratios aren't reliable indicators of effect size. I thought that they were. That's how I always interpreted them, but they're not. And the reason for that, this is the only crazy math equation that I've kept in here, but basically logistic regression is a combination of some constant, your independent variables, so your explanatory variables, and then an error term, right? This error term encompasses basically the residual variance in a logistic model that because you haven't put every explanatory variable that you possibly could into that model. So typically when we look at how an odds ratio is calculated, we would always say you just exponent the beta coefficient. So it's the power of the beta coefficient. But that's not true. In order for it to be a cumulative distribution function, meaning in order for us to actually do logistic regression on this, we have to divide the beta coefficient by an arbitrary factor. This arbitrary factor is the variance of the residual error. And so just know that every time I add a variable to my model, that sigma down here changes. So that means that every time I add an explanatory variable to my logistic regression model, my odds ratio changes. So if I put a variable in there that was an independent variable, then every time I add an independent variable to the model, my odds ratio goes up. So that means that there's no single odds ratio to explain association between a risk factor and an outcome of interest. And we think of it in terms of confounders. If there's an association between the terms that I'm adding, then maybe the odds ratio goes down. That's what we're used to seeing. Adding variables to a model, the odds ratio going down. So this has several implications. So if there's no unique odds ratio, that means that different odd ratios from the same study, if they were created from different models, don't compare to one another. And if I look at different studies and try to compare the odds ratios between different studies, those don't compare to one another. And I can't tell you how often we look at subpopulations. So I do a sub-analysis and say, in this subgroup of patients, my odds ratio increases to 10 when it was 5 before. That's meaningless. I've used a different model. There's a different arbitrary scaling factor. So it could just be that the model was different and the odds ratio is now 10 instead of 5. I can't compare even subgroups in my same data set. And that means that the magnitude of the odds ratios can't be compared between systematic reviews. So it's a marker of effect size if I'm comparing certain variables in the same model and I want to see how much they contribute, but only in that same model. So why are there so many odds ratios in the literature if it's so hard to interpret? Because they're simple to calculate. They apply to both continuous and categorical variables. They show the direction of the significance, so if we want to find that out, it's important. In some studies, you can't measure what the prevalence is. If you're doing a case control study, you're selecting how many cases you're selecting how many controls. So you're arbitrarily setting what the prevalence of the disease is in your sample population. So there's no way you could calculate a relative risk in a case control study. Odds are the best that we have. And when we're analyzing a binary outcome in terms of multivariable logistic regression, when we control for confounders, it's easiest to do in terms of odd ratios. So how should we think of an odds ratio? To say that the estimated odds ratio is 1.5 is probably factually incorrect. There isn't a single odds ratio available. If we look at an estimated odds ratio of 1.5, that's a little more accurate, but it's still imprecise. So you may not write this in every paper that you publish, but the way that you should be thinking about this is that the estimated odds ratio is 1.5. It's conditional on the explanatory variables that I put in the model, but a different odds ratio would be found if I put different explanatory variables in there. The 1.5 estimated odds ratio cannot be compared to odds ratios estimated from other data sets, and they can't be compared to odds ratios from the same data set with different explanatory variables. Again, nobody's going to write that out, but you have to be thinking about that when you read an odds ratio. The next thing is the alpha of 0.05. We all know it's an arbitrary cutoff. A lot of us interpret that as a false positive rate of 5%. We reassure ourselves that if the significance value is 0.05, there's only a 5% chance that I got this wrong. But that's not actually true. Again, I would argue that the false discovery rate is closer to 35%, and it depends on what you like the probability that the statistically significant result that you found is actually true. And so the best way to think about this is in terms of a diagnostic test. So suppose I have 10,000 patients, and I say that the prevalence of osteoporosis is 1%. It's a fairly rare event. So now I have 100 patients with osteoporosis, and I say the sensitivity of my test is great. It's 80%. And so if I put that test on 100 osteoporosis patients, 80 of them are tested correctly as osteoporosis. 20 of them are false negatives. If the prevalence is 1%, that means 9,900 patients don't have osteoporosis. But the test is, again, good. It has a specificity of 95%, which means that, there's 9,400 true negatives, and I have 495 false positives. So I'm looking at a diagnostic test that has a great sensitivity, it has a great specificity, but it's relatively rare. Osteoporosis is a rare disease. So my false discovery rate is 86%, right? I divide my false positives, 495, by the total number of positive results I got. Does that make sense? Sensitivity and specificity are great, but they change in the context of the prevalence of the disease. So now I think about it in terms of articles, right? What is the chance that I have a hypothesis that's actually true? I would say that on average, we don't know this, right? Because negative results aren't published. But let's assume that it's about 10%. I'm looking at 10 bone substitutes, and I want to see how many of them perform better than iliac crest. Maybe 1 out of 10 performs better. So then I have 100 studies that have my hypothesis that's correct. The power of the study is 80%, similar to the sensitivity, so I get 80 true positives. And then the alpha is 0.05, which is the same thing as specificity, so I get 45 false positives. So if I assume that I'm good, and 1 out of 10 of my hypotheses are correct, that means that if I look at the literature as a whole, 36% of my results are false positives. So let's assume that now I'm a brilliant clinician. 1 out of 2 times I get the hypothesis right. Then if you work through the math, it's roughly 6%. Then my false positive rate's 5%. But that shouldn't be reassuring to you, because this is in the ideal situation where treatments are applied to patients at random and we're only doing a single comparison. So how often is that the case in a retrospective study where the surgery is applied to the patients at random? Most of the times it says that the indication for the procedure was at the discretion of the treating provider. Now let's take the situation where we're underpowered in our study. The situation gets worse. If you're underpowered, that means that your false positive rate goes up. So that argues against people who say, it's a retrospective study, we only have 100 patients, let's just run the statistics and see what we find. Well, if you do that, then the chances that you have a false positive actually go up. And if we're brilliant clinicians, it's 10%. If we're an average clinician, it's 47%. So half the times we're wrong. So then I looked at these editorials that were in journals, and they were trying to describe to people what the pitfalls of the p-value are. And granted, this isn't like the greatest journal. It's the European Journal of Dentistry. But what they're teaching people is, hence, a low p-value in a small study is more evidential than a small p-value in a large study. We just showed that that's false, right? If you have a low p-value, the same p-value in a small study, in an underpowered study, your chance of having a false positive is actually higher. You've identified an outlier group of your sample where the effect size is super large, and therefore you still found a significant result. It's likely not representative of the population. This is not getting into the science of things, but basically this distribution here is a mean distribution of 0, standard deviation of 1. So basically it's a dummy data set where, there's nothing is happening there. And then I sampled this population 100,000 times. And so essentially the same samples are occurring in the two groups, right? The mean should be 0, the standard deviation should be a little narrower. When I run two-tailed t-tests on this 1,000 times, what you get is p-values that sort of make sense, right? 5% of your p-values are less than 0.05. That's great. But if you look at the distribution, it's flat. So the probability that my p-value is less than 0.05 is the same as it being between 0.05 and 0.1, between 0.1 and 0.1.5. So there's no structure to these p-values. It's completely random when your null hypothesis is false. That's pretty scary. So if you have a null hypothesis and someone is reproducing your study and you make a claim, my p-value is 0.07, I'm trending towards significance. If your hypothesis is wrong, the next time someone tries to replicate that study, the p-value could be 1 of anything between 0 and 1, right? It's a uniform distribution. Now if we look at two samples where the mean separates by 1 and the standard deviation is still 1, I sampled that data set so that I had 16 samples, 2 groups, and now there is a true difference, right, between the data, and it's powered towards 80%. So now when you look at the distribution, my mean difference is 1, and I have an 80% power, so my p-values for 0.05 cluster around here. Like I have 80% of my p-values below 0.05. Now things make sense, right? Now a trend towards less than 0.05 makes sense. That statement only makes sense if your hypothesis was actually true, which maybe is true 10% of the time. And the other thing you ought to recognize is that as my power decreases, for the same alpha significance, the effect size has to go up. So if you do an underpowered study and you find a significant result, chances are you're overestimating the effect size, if you're true at the end. So another reason this statement is false. So pitfalls of the p-value, using the p-value to assess the magnitude of an effect or the importance of a result. It's not, it's just telling you if it's significant. Using the p-value as the basis of your scientific conclusion. Just because the p-value is low, it doesn't really matter. We've all seen registry studies where the clinical effect size is pretty small. And reliance on the p-value cutoff. And so these are like hypothetical abstracts that highlight these concepts. So this is one where you're looking at lumbar arthrodesis and you're looking at the risk of a readmission based on your age. So this abstract concludes that there's no difference based on the age cutoff because the p-value is greater than 0.05 and there's no association between 30-day readmission rates. But if you look at this table and you calculate the risk ratio, because for prospective and retrospective studies you can calculate it, the risk ratio is 1.96. Confidence interval is fairly narrow, 0.95 to 4, and the p-value is 0.07. So the authors conclude there's no difference, but the relative risk is pretty high, right? There's a 96% higher chance that people older than 65 are readmitted in 30 days. So most policy experts, most clinicians would argue that that's something that we ought to pay attention to. Then you have like a large database study. It's looking at joints arthroplasty and the incidence of pulmonary embolism, again by age cutoff. This time the authors conclude that there's a strong association between age and pulmonary embolism because the p-value is super low. And therefore, older age is a strong risk factor. What they're doing is using a low p-value to give us a surrogate for the effect size, right? But if you look at the risk ratio here, it's only 1.12, right? And so many would argue that this isn't really a strong risk factor, and so we have to caution ourselves. And so when we interpret results, I've given you a lot of information, I think the way you do it is by looking at the effect measure that you're using. Are you using risk ratios, which are easy to interpret, or are you using odds ratios? Can you use risk differences? If so, calculate them, because you know the same odds ratios of 2 for that men versus women mortality thing can lead to very different probability risk differences. Use the 95 confidence interval. Use the p-value. There's journals like Journal of Hand Surgery that advocate in the table, if the p-value is less than 0.05, to just report it as such. I would advocate publish the actual p-value. And use contextual factors too, like what is the mechanistic probability of the finding actually being true, and is it compatible with prior well-done research? Last thing, sparse data bias. This is something that's hiding in broad daylight. It's recently been brought to our attention in CORE in 2017, and it leads to very misleading effect size estimates, and some key red flags are that you have a small number of events in the groups of interest. And so this is a hypothetical scenario where we're looking at joint arthroplasty and ICU admissions. And they're saying, there's only 10 events total, 6 in the male cohort and 3 in the smoking cohort. And it's a fragile result. And the fact that there's a few patients should lead you up to that. For example, if one patient was added to the ICU group, my odds ratio goes to 5.4. If one patient was taken away from it, it goes down to 2.3. So it's fragile. The next thing is it's high odds ratios with wide confidence intervals. So if you look at current smoker, the odds ratio is 38, but the interval is 3.5 to 416. That's not meaningful. Like I can't draw a conclusion from that result. Furthermore, if I just took one additional patient in there, the odds ratio drops to 19. That doesn't occur in the real world. And furthermore, it's giving me an adjusted odds ratio based on adjusting for male sex. But if you look, there's only one patient not admitted. That one patient is either male or female. So how would you possibly adjust by sex? But the statistical software is out there will give you an adjusted odds ratio. So you have to be careful of that. And when it does give you one, the intervals are massive, right? So now the confidence interval is 186 with an upper bound of 3,700. So if you see odds ratios, wide confidence intervals, that get larger when you do a multivariable analysis as opposed to smaller, you should be thinking that there's sparse data. So there's subgroups here where there's barely any patients in them. People think that this is a problem in small data sets, but it exists in large data sets too. So this is Parvizi's article from JOA. It's out of the Mayo Clinic, and they looked at exactly that, ICU admission rates for total joint arthroplasty. And if you look at male ever smoked cement and general anesthesia, their univariate odds ratios are relatively small. Then they do multivariable odds ratios after controlling for 11 factors. And you go from an odds ratio of 1 to 55 with an interval of 1 to 1800. This was published in the Journal of Arthroplasty. If we take these odds ratios to be true, that means that a male smoker who underwent cemented total hip arthroplasty, has a 13,000 times greater odds of ICU admission. Makes zero sense, right? It's clearly a statistical artifact. So sparse data bias, know when it occurs based on wide confidence intervals. It occurs because there's a lack of adequate case numbers when you start to subgroup, when you start to control for enough confounders. We were historically thought, if there's 130 cases, you could control for 13 variables in the model. 1:10. That's not true, as Parvizi's article showed. This is another article that shows kind of the same thing. So to summarize, when you're sifting through the literature, look at journals, topics, and authors, and use a service that will amalgamate those papers for you quickly into a reference manager. Then apply a set of screening questions to it, and then look at common misinterpretations and don't get fooled by the data. So look at p-values, effect measures, and sparse data bias. Thanks. Questions? Yeah.
Even though you promised not to get nerdy on us. So I guess, one of the questions is, when you see the number of articles going up in each journal on issues and stuff, and then you keep picking out articles saying, what this article says, can we be said, really find the true statistics. It seems that what you're really lobbying to do is to say that the journals in general have to do a better job with statistical analysis. It's not practical, I know one would say it should be true, it's not practical for me to take each article that I'm being swamped with and dig into every number and say, can I really believe this, even though maybe I should be doing that. It really seems that what we're saying is that the responsibility needs to go back to the journals that are putting this out that make it seem like, hey, it's peer reviewed, it's real. And maybe you're in a position to write an editorial to say, maybe the journals need a little more responsibility on this front to be more selective.
Yeah, I will openly admit, like, I don't know how to do any of these statistics. When I started residency, I thought that I would do statistics, and I've quickly realized that, 5 years of orthopedic surgery, I can barely keep up with orthopedics. And there's people who do statistics for a lifetime. They probably understand it better than us. What I'm advocating for is an intuitive understanding. So even if you didn't know how to do the statistics, how do you recognize if something's wrong? I agree with you. Editors should do a better job. Reviewers should do a better job. But we've all seen the mechanisms fail. I mean, CORE has a bunch of examples of sparse data bias that they've identified back, like at least 20 articles. And so I think you still need to have an intuitive sense. I mean, this is how we learn today, right? And so to say that the entire onus of knowing whether something's true or not lies in the hands of the reviewer or the editor, it seems like maybe 10% of the time that you spend reading articles ought to be spent on, well, how do you read an article? And how do you interpret it? And there's enough articles about that.